In this picture you can see actually that in the continuation of the stomach we have at first the small intestine and then the large intestine, and today we will discuss the histological structure of these parts of the gastrointestinal tract. So here on the right side you can see a schematic drawing about the different parts of the small intestine, so duodenum, jejunum and ileum, and then in the lower part this is the large intestine, and you can see here the main characteristics of this part. But we will see the same layers everywhere, and these are the layers we have already mentioned. So the same layers we also have in the esophagus and the stomach. So the innermost one is called mucosa. Here you can see that with this blue contour, with this blue line, it represents the epithelium. The epithelium is a simple columnar epithelium with striated border and lots of goblet cells. This is characteristic for the entire gut. Yes, so everywhere we will see this epithelium naturally with lots of tight junctions. Under the epithelium we will have this lamina propria mucosae, loose connective tissue, and in this layer we will see lots of glands. These glands are called cryptocum or intestinal glands because they look like a crypt, so these are simple tubular glands, and we will find these glands everywhere. Yes, so both in the small and in the large intestine. And they extend as far as the muscularis mucosae. This is this typical muscle layer of the gastrointestinal tract in the mucosa. Under the mucosa, the next layer is called submucosa. This is again loose connective tissue, and you will see that in the different parts of the small intestine we will see special structures. We will also discuss these structures today. And what we cannot see now, but the submucosa forms so-called folds. These are extensions of the submucosa. Then the muscle layer is the next one, muscularis, which can be also here divided in two layers into an inner circular and outer longitudinal layer. Between the two layers we will also see the neurons which belong to this mesenteric plexus. In the submucosa we also have this nerve plexus, the Meissner plexus. But about this plexus I won't speak today anymore. Last time we mentioned this nerve plexus in details. And the outermost layer is can be different, so serosa if the gut is covered by the peritoneum, or adventitia if it is not. Yes, so adventitia is a loose connective tissue, serosa corresponds to the mesothelium. So let's start with the small intestine a little bit more in details. You can see here on the left a schematic drawing of the wall of the intestine. On the right side, this is a histological slide stained with hematoxylin eosin. If you start here with the muscle layers, so a little bit under the muscle layer should be the outermost layer. In case of the small intestine, this is almost always serosa. Only in some parts of the duodenum we do not have a peritoneal covering, but it is not now in this picture not visible, but should be here at the bottom. Then longitudinal circular muscle layer, submucosa, and you can see the folds here. So the folds correspond finger-like projections which are also macroscopically visible. So you will see these folds in the dissecting room as well if you open the gut. And it is then covered by the mucosa, yes, completely. And you can also see that the mucosa also have lots of projections. These are the villi, yes, and I want to emphasize these villi. These are called intestinal villi, and these are characteristic for only the small intestine, but in the entire small intestine we will see these protrusions. In the axis of this villi we will see the lamina propria. So if you check this picture on the right side, all these projections which are either in longitudinal or cut or in cross section, these are these villi which are naturally covered by the surface epithelium. And in the lower part of the mucosa, these will be the glands, the crypts of Leverkuhn. But I show you another picture about it here. You can see again the villi which extend into the lumen, and these are always formed by the lamina propria. This is very important. Yes, so the villi are covered by the surface epithelium. This is simple columnar epithelium with striated border, as I mentioned, and lots of goblet cells. And the lamina propria forms this villi.
Excuse me?
Yes?
These intestinal villi, they are different from the microvilli?
Yes, the macrovilli are the cytoplasmic projections of the surface epithelial cells. Yes, these are with this magnification not visible, but they should be here on the top of the epithelium. I will show you also a picture where you can also see the microvilli. Yes, but the microvilli are 1 micrometer long, so these are only barely visible with light microscope, but these intestinal villi are projections of the lamina propria, and these are longer.
Okay, thank you.
Okay, so this red dotted line represents here the muscularis mucosae, and as you can see that the submucosa also forms projections. These are called folds. Without the muscle layer we won't speak anymore in details, and serosa adventitia is not visible. But let's speak about the mucosa a little bit in details, and here you can see again these intestinal villi. These are, as I mentioned, these finger-like projections which are covered by the surface epithelial cells, and these are also a little bit macroscopically visible because the length of the villi is about 1 millimeter, and so that the surface of the gut will be like velvet. And in the light microscope, we will only see a light eosinophilic stripe. Sorry, we will also see this villi, but so do not mix it up with the microvilli. The microvilli should be the cytoplasmic projections of the cells, and we will see the microvilli only in form of thin eosinophilic layer on the top of the epithelial cells. The crypts are invaginations, yes, of the surface epithelium. So these are glands, simple tubular glands which are lined by different cell types. I will also speak about the glands in details. And if you check this light microscopic picture, so the villi will occupy the upper half of the mucosa, and the crypts we will see in the lower part of the mucosa. They extend as far as the muscularis mucosae. So this slide you have actually already seen, yes, about the small intestine, as we learned this epithelium, the simple columnar epithelium with goblet cells and striated border, yes. So this striated border corresponds to the microvilli here. This is on the top of the epithelium now. The cells of the epithelium can be also called enterocytes in the small intestine. And if you check again this villi here, in the center of each villus we have loose connective tissue. So this is the connective tissue of the lamina propria, which contains lots of small vessels, arterioles, venules, capillaries. And what I want to emphasize is that in the center of this lamina propria, you will see a lymphatic capillary called central lacteal, which will be very important in absorption the fatty components of the fatty components of the content of the gut. And the muscularis mucosae has a function that the contraction of these muscle cells can help the veins and this central lacteal to empty their secretion, so they contend into larger veins or lymphatic vessels. The capillaries and also the central has a fenestrated endothelial lining. Yes, it's also important so that these nutrients can enter the bloodstream and the lymphatic system easier. And here you can see the striated border, but we have already learned it, so please repeat it from the first semester, the structure of this microvilli. So these are mainly electron microscopically visible. So here you can see this cytoplasmic projections which are covered by the cell membrane. Yes, here this is a cross section, and here you can also see that in the center of this microvilli we always have microfilaments. Yes, actin filaments. These actin filaments form the skeleton of for these projections, and they can. Yes.
Excuse me, another question. Could you just define what you mean by fenestrated endothelial lining?
Yes, fenestrated endothelium means that you have gaps between the neighboring endothelial cells. So the wall is not continuous. I will show you right now in one of the slides to show it. Yes, in a schematic drawing I can do it again then. Yes.
Thank you very much.
Okay, so with pus staining, you can see here now the same epithelium stained by pus hematoxylin, which and this staining makes the goblet cells visible, and also on the surface, this layer where you also have the microvilli, but actually the mucous film is here stained, and this mucous film is produced partly by this goblet cells, but we also have molecules bound to this cell membrane which contain carbohydrate components, so lots of glycoproteins are bound to the cell membrane, or glycolipids, or lots of enzymes, and these molecules all together form the so-called glycocalyx or sugar cord, which is also pus positive. So if you check these electron microscopic pictures, you can see that the microvilli are actually embedded in this mucous film, and this is what is now strongly pus positive. So this is the schematic drawing. Can you see here on the bottom, you can see these fenestrated vessels, fenestrated capillaries. So these are the endothelial cells, and there are gaps between the cells, and the basal membrane is not continuous either. So, and that's why important, so that the molecules can pass the vessels easier. And this schematic drawing shows that the amino acids and the carbohydrates, so the monosaccharides, will enter always the blood capillaries during absorption. Yes, they will be taken up by the cells with an active transport, and then they can reach the bloodstream. On the contrary, so the fatty components, so the monoglycerides will enter the cells with a passive transport, but as you can see, they will go further in, not into the blood capillaries, but they will be taken up by the central lactea. So they will enter the central lactea, this lymphatic capillary. And as you can see in the picture, from the monoglycerides, at first, again, triglycerides will be formed inside of the cell, and the triglyceride molecules will be surrounded by the protein molecule, and these two together will form the so-called chylomicrons, and these chylomicrons are these small units which can then enter the central lactea. Yes, and as you can see here, the content of these lymphatic vessels is a little bit different from a normal lymphatic capillary because it is very rich in these lipid components, yes, of the nutrients. And it has a whitish color, that's why. Yes, so the lymphatic vessels coming from the gut, mainly from the small intestine, contain this fatty lymph, this fatty lymphatic fluid called chyle. Yes, and later it will naturally enter the main lymphatic vessels, so the thoracic duct, and then the fatty components will also enter the bloodstream. Okay, so let's go further now to these glands. Yes, so we discussed here now these villi, and if you have a look at this picture, the glands, the simple tubular glands of the small intestine are found in the lower part of the mucosa, and they always enter the surface between two villi. And if we enlarge them, we can see that they can be lined by different cells. So these very light cells are goblet cells. In between the goblet cells, you can also see the surface epithelial cells. And at the bottom, you can see strongly eosinophilic cells, here with hematoxin eosin staining. This will be the so-called Paneth cells. I will show you right now a schematic drawing about these cells. And with pus staining, you can also see these cells, the goblet cells, will appear in this purple color. So what are these cells which can line these glands? Altogether, 5 cell types can be distinguished here. As I mentioned, the surface epithelial cells can be present in the glands, or these goblet cells which produce mucus, lots of enteroendocrine cells. Yes, what does it mean? Enteroendocrine cells produce hormones which will be released into the bloodstream, but you do not have to recognize these cells in our slides now. So to show these cells, we should take special immunohistochemical staining methods. Or undifferentiated cells are also present, and from these cells, not only the glands, the glandular cells, but also the surface epithelial cells will be replaced. And these are cells which are dividing, yes, so they have a very high mitotic activity. Every 5 days actually will be the surface epithelium changed. And clinically these are also important because these cytostatics act normally on the cells which are the intensively dividing cells, and that's why a side effect of this treatment can be a diarrhea when actually the epithelium of the gut is destroyed. And the fifth cell type are these from these Paneth cells I mentioned before. Yes, Paneth cells are always found in this basal part of the glands, and they contain lots of strongly eosinophilic granules in the apical part of the cytoplasm, and they produce antibacterial substances like lysine or alpha-defensin. Yes, and we can see these cells very well in our slides. Yes, here you can see the cells shown by these arrows in this cross section of the glands. And you see these strongly eosinophilic cells correspond to the Paneth cells. They can be also visible with pus, but you have to be careful because pus staining stains also the goblet cells. Yes, and but we will have slides with hematoxin eosin in this semester, and you will see then these eosinophilic cells. These will be the Paneth cells.
May I ask another question?
Yes, please.
You say they produce the antibacterial substances in granules. Do they release those in vesicles, or do they, like, they release them, right?
Yes, they are. Yes, the substances are found in these granules, and they will be released with an exocytosis, actually.
All right.
Lumen.
Thank you.
So, this slide shows that the villi and the crypts can be also visible in cross-section in our slides, and sometimes it can be a problem to distinguish between these two structures. And to avoid this, made Dr. Judith Horvath, these models to show that if you have a villus, you will see in the center of the villus the lamina propria. Yes, because these are actually projections of the lamina propria, and around the villus you will see the lumen of the gut. So actually you could say nothing around something characterizes the villus. A crypt is, on the contrary, you can see the lumen in the center of a crypt, because the crypt is actually a gland, so an invagination of the epithelium. But around the gland you can see the lamina propria, where actually the glands are embedded in. So something around nothing could be thought in this case. What are the faults? Here you can see two pictures next to each other with hematoxin eosin, and in both cases you can see the villi again. So villi are these projections of the lamina propria. Yes, but in both cases you can see also a fold, but the folds are always projections of the submucosa. Yes, and that's why the folds are the folds covered by the mucosa. And these are only visible if you have longitudinal sections from the gut. Yes, you can make it on these two endoscopic pictures to understand it. Can you see the folds are arranged always circularly? Yes, in the gut. That's why also called circular folds or Kerckring's folds. And it is very characteristic for the entire small intestine. And if you have a cross section from the gut wall, then you won't see the folds. But if you will cut the gut in the length like this, then the folds will appear only. So it can also help you to say whether you have a cross section or a longitudinal section from the gut, because if you can see the folds, it must be a longitudinal cut. And if you check the muscle layer, if you have a longitudinal section, the outer longitudinal layer will appear so the muscle cells there will appear in longitudinal section. So altogether we have actually three structures which can increase the surface. And here you can see the structure. So on the bottom, this is a surface epithelial cell, yes, an enterocyte. And can you see these are the microvilli, cytoplasmic protrusions covered by the cell membrane. In the center, you have the cytoplasm with actin filaments. These are the microvilli, which are only 1 micrometer long. That's why we can barely see them with my light microscope. Only with electron microscope we could see the separate villi, with separate protrusions. But these have the largest surface increasing factor, 30 times will be the surface larger. The villi are protrusions of the lamina propria, so these are covered by the surface epithelium. Yes, and the length is 1 millimeter, so we can see them with light microscope, but a little bit also macroscopically. They can increase the surface 5 times about. And folds are larger, again, 1 centimeter long are they, and these are protrusions of the submucosa, and that's why they will be covered by the entire mucosa. Yes, so don't mix them up, but this schematic drawing helps to understand it. Yes, and the folds are always circularly arranged in the small intestine. Okay, so these were the general features of the small intestine, so the villi, the crypts, and the surface epithelium. But how can we distinguish between the three parts of the small intestine, between duodenum, jejunum, and ileum? Here you can see it, yes, in the following slides. You have to check the submucosa always. Yes, and if you can see glands in the submucosa, that will be the duodenum. And these glands are called Brunner's glands. These are mucous glands, so as you can see, they are not stained. And these will be tubulo-alveolar glands morphologically, and they naturally also have a contact to the lumen. They open into the crypts. Yes, here you can see an area where a gland opens into a crypt. And with another magnification, this is here on the right side, you can see that these glands are light eosinophilic or grayish because they produce mucin film as well. And if you consider, it's very important in the duodenum because the duodenum is the direct continuation of the stomach, and the role of the mucin is to neutralize the gastric acid which enters the duodenum. So that is characteristic for the duodenum. If you cannot see these glands, and if you practically cannot see anything special in the submucosa, then you have the jejunum. Yes, both slides are, you can see here, are made from these parts, so from the middle part of the small intestine. Maybe some solitary lymphatic follicles can be present, but solitary lymphatic follicles can appear everywhere actually. And you can see lots of lymphatic follicles, so-called aggregated lymphatic follicles, so lots of follicles next to each other in the submucosa. That will be the ileum, so this most distal part of the small intestine. And these structures are called Peyer's patches. Patches because they are found not in the entire length and in entire cross-section of the gut, as you can see here. They are only found at the so-called anti-mesenteric part of the gut wall. What it means, you will learn it in anatomy. So the mesentery is this double layer of the peritoneum which connects the posterior abdominal wall with the intestine and fixes the intestines, and then the mesentery and the peritoneum will then cover the small intestine. And yes, on the opposite side of the mesenterial end, you will always see these Peyer patches. So this is very characteristic for the ileum, and in all of our slides you will see it, but not always you will see so well the separate follicles. It can also occur, like here in this picture, that the lymphatic follicles are so close to each other that you cannot see the border between each follicles, but you will see that the entire submucosa is infiltrated by these lymphocytes. So this is very characteristic for the ileum. And the cells can also migrate into the mucosa, so into the as I want to show it here, so into the lamina propria of the mucosa. Yes, so that's why the structure of the mucosa will be a little bit modified here. You can see, to understand it, you can see here a scanning electron microscopic picture. So these smaller protrusions are the villi, which are characteristic naturally also for the ileum, but where you have these pair patches, the epithelium won't show either villi nor crypts. So in this area, as you can see it here, so the epithelium forms a dome-like protrusion only. And if you check the epithelium, it will contain special cells called M cells. In the middle, you have this type of cells. Yes, so these are embedded in between the enterocytes, in between the normal enterocytes, but these are special cells because they have they can surround lymphocytes, as you can see here, and they make the lymphocytes easier to have the contact with the antigens, which can be found in the lumen of the gut. So the M cells or microfold cells, they do not have microvilli, only some smaller folds, but these are very characteristic for this area, but you do not have to recognize these cells in our slides. Yes, so it is only theory. Yes, and as you can see in the follicles, we have lots of mobile cells, mainly B cells, but naturally also antigen presenting cells like follicular dendritical cells or other macrophages. Yes, so you have already learned about the lymphatic system, and you will speak about this lymphatic system in the practice as well. So that was the small intestine with these three parts, duodenum, jejunum, and ileum, and now let's continue with the large intestine, which is composed of the cecum, ascending colon, transverse colon, descending colon, sigmoid colon, and at the end we have the rectum. But histologically, the large intestine is quite so we do not have differences between the different types. Only in the rectum we have special areas. At the end of the lecture I will also speak about the rectum. But how does it look like, the large intestine, so colon? You can see here in this picture. And if you check the layers, the most important difference between small and large intestine is that we do not have any villi here, only crypts. Yes, so as you can see in the picture, we have these invaginations, so we have these intestinal glands. These are also simple tubular glands, but we do not have these projections anymore. Epithelium is the same, yes, so simple columnar epithelium with microvilli. We also have folds, as you can see here, so protrusions of the submucosa, but these folds have a semicircular arrangement. The details about it, why is it like this, you will learn in anatomy, yes, so histologically you can also see folds here. And the other layers are the same, yes, so inner circular, outer longitudinal layer, and so the outermost layer can vary, adventitia or serosa. It's again anatomy, which parts of the large intestine have a peritoneal lining. So a little bit higher magnification, yes. The surface, what I want to emphasize is that both on the surface and inside of these crypts we will have lots of goblet cells. Yes, goblet cells produce mucus, and if you consider it, a very large amount of the feces is made by the mucus. Yes, so it is produced by these cells. The surface epithelial cells can also be called colonocytes in the large intestine. And both cell types can occur also in the glands, and also enteroendocrine and reserve cells, but these two lower, so these two cells you do not have to recognize in our slides. And it's also very characteristic that in our slides we will see the glands in cross sections mainly. Yes, it is caused by the plane of the cut. A special area is the appendix vermiformis. This is a small protrusion of the circum. You will learn it in anatomy. And in this part of the colon, we have again lymphatic follicles which are aggregated, so in groups. And as you can see, they also infiltrate the mucosa, and that's why the epithelium is not so good recognizable, but you can also see that also we also have crypts here, but it is a little bit similar to the ileum. Yes, so it belongs actually to the lymphatic organs. And clinically, you have probably heard about the appendicitis. This is a very common inflammation of this appendix vermiformis. And gut, if you hear this word gut, this is the abbreviation of gut-associated lymphatic tissue, and we understand all the lymphocytes which can found in the intestines. So not only these aggregations of lymphatic follicles, but all the solitary lymph follicles or lymphocytes which appear in the gut wall. Clinically, the colon is very important. Lots of diseases can occur here. I want to emphasize the carcinoma of the colon, which is a malignant tumor, which is very common, a common disease, unfortunately. And yes, that's why it's important to know the structure of the large intestine. Hirschsprung's disease we have actually mentioned last time when we spoke about the enteric nervous system. If you remember, in this case, these inhibitory neurons of the mesenteric plexus disappear, yes, from the rectum or sigmoid colon, and that's why we will have a tonic contraction of the muscle cells, and the content of the gut cannot be emptied. And as you can see, the proximal parts of the colon are enlarged. So in this case, you have to remove this obstructive part of the gut. Okay, and at the end, some words about the rectum. This is the last part of the gut, and practically it can be divided into two main parts: intestinal part and anal canal. The intestinal part shows the same structure like the colon, so I won't speak about it in details. The anal canal is about a 4 centimeter long part, which can be further divided in three main parts. The first one is called columnar zone, because here you have longitudinally arranged protrusions, columnar protrusions of the submucosa again. So these are actually like folds, protrusions of the submucosa, but these are now longitudinally arranged, not circularly or semicircularly, and these are formed by arteriovenous anastomosis, and the function of these folds is actually to keep the opening closed. Yes, so to keep the anus opening closed. So not only the sphincter muscles close this opening. This so in between the columns we have the so-called sinuses, anal sinuses. These are deepenings, and at the lower part we can also speak about anal waves. So similarly to the valves of the heart, they look like they are they form the border between the columnar zone and the next zone called hemorrhoidal zone. In this zone, the epithelium will be already squamous epithelium, so non-keratinized squamous epithelium, and it is called like this because the so-called hemorrhoids, starting from these arteriovenous anastomosis, will appear in this zone mainly. And the outermost zone is covered by the skin. Actually, it's called, that's why, cutaneous zone. And pectinate line should be, so this wavy line, this wavy border between the hemorrhoidal and columnar zones, and this is an important embryological and anatomical border as well. So here is the cloaca membrane located during development, so everything which develops above it, so every epithelial structures are derivatives of the endoderm, and under it of the ectoderm. Yes, so this is what you have learned in embryology, and the anatomically it's also important because the blood supply changes here of the rectum. And we have in this area two sphincter muscles, an inner and an outer. The inner one is a smooth muscle, the outer one is a skeletal muscle. Sphincterani internus and externus muscles. Sure, they will be visible better visible. So this is a hematoxylin eosin stained slide. On the left side, you can see the lumen of the rectum, and as you can see, the lumen is so inside of the lumen you can see the scalum, so it is interrupted actually by the scalums, but it is due to the plane of the cut. It is a longitudinal cut of the rectum, and that's why we can see the columns in the middle of the lumen. And on the right side, this is the gut wall, so the submucosa should be here, and then the muscular layer divides then in two layers. The inner sphincter muscle, the sphincterani internus muscle, is actually the continuation of the inner circular muscle layer, and this is a smooth muscle. The outer is a skeletal muscle, as I mentioned, but in newborn babies, and the slides are made from a newborn, it is smooth muscle, yes? And actually the muscle fascicles are surrounded by this smooth muscle layers, by thin smooth muscle layers, which correspond actually the continuation of the outer longitudinal muscle layer, but inside of these units later the skeletal muscle fibers will appear. Yes, and if we enlarge an area, we can actually, not always, not everywhere, but here, for example, we can already see some skeletal muscle fibers with eccentric nuclei. Yes, so this is skeletal muscle already. In the rectum, we will have epithelial transitions as well. So this is again this longitudinal cut from the rectum in the lumen. You can see the lumen in the middle, and in the intestinal part, and also in the anal sinuses between the columnae, you will have simple columnar epithelium with microvilli. So that's the typical epithelium of the intestines. But if you check the surface of the columns here, this island-like structure is a column in longitudinal cut, and if you enlarge it, you will see stratified columnar epithelium on the cut. In newborns, it is this epithelium. If it was made from an adult, the epithelium would be stratified columnar non-keratinizing epithelium, but here in our slides we will see stratified columnar epithelium. And in the next zone, in the columnar zone, if you enlarge this zone, you will see stratified non-keratinizing epithelium in the hemorrhoidal zone, and in the stratified squamous keratinizing epithelium. So this is actually skin. Clinically, you can see here some, so how the hemorrhoids look like. Yes, these are, as I mentioned, arteriovenous anastomosis, which can be also, which can cause lots of symptoms. So it's not important for the exam, but if you are interested, under this link you can have a look at an operation, a surgical treatment of these hemorrhoids. At the end, I want to summarize how you can distinguish between the different slides we will have in the gastrointestinal tract. So at first, I would emphasize that we have this muscularis mucosae, which is only found in the GI tract. And if you see villi, if you see these protrusions, like in these cases here, you will have a slide from the small intestine. And to distinguish between the three parts of the small intestine, you have to check the submucosa, and if you see the Brunner's glands, it will be the duodenum. If you do not see anything special, it will be the jejunum, and if you can see the pale patches, that will be the ileum. If you do not see any villi, then you have either the stomach or the colon. You have to check the epithelium because this is not the same. In the stomach, you will have this simple columnar epithelium without microvilli, but this will be a secretory epithelial surface made by surface mucous cells. And in the colon, you have the simple columnar epithelium with striated border and with lots of goblet cells. Yes. If you are unsure, you can check the glands again. And in the corpus or fundus of the stomach, the mucosa will show these three levels. Yes, in the uppermost level, you will see these typical invaginations, the gastric pits, which appear light eosinophilic. Then in the lower part, you appear the glands, and the neck parts of the glands will be whitish, so they are not stained, because here the mucous cells, the mucous neck cells predominate, and in the basal part of the glands you will see a basophilic staining, because here the chief cells predominate. So if you can see these three colors, eosinophil, colored, and colorless, and basophil, so bluish color, it must be the corpus or fundus. In the pylorus, you have, in pyloric part, you only have an upper eosinophilic area in the mucosa, because here you have these very deep gastric pits, but the glands are only lined by mucous cells. That's why the lower part of the mucosa will appear relatively light. And in the colon, you will only see these invaginations, yes, and that's why we see only at one level. It corresponds to intestinal glands. And you had the cardia, but in the cardia of the stomach, you will always see the epithelial transition, which is very characteristic. Okay, so thank you very much. That